Oh, hello.
Yeah, a weird number.
Okay.
More pathologists always. That's all.
All right. It is 8 o'clock, so we will go ahead and get started. Good morning, everyone. I'm Gillian Shaw. I'm one of the pathologists here in Coplow. And I will start with the first case, which is shown here. So this is an eye from an 11-year-old domestic short-haired cat. The history we received was suspect unknown trauma to the eye before adoption, which was greater than 5 years ago, and the eye was blind. They said recent onset of redness and squinting. The exam shows what appears to be posteriorly positioned cataract with posterior synechiation, possible pre-iridoid fibrovascular membrane, and removal due to risk of sarcoma. So this eye was not actually glaucomatous. The IOP was 15 at the time of enucleation. The cat's other eye is within normal limits, and there were no other reported general medical conditions. So here is the eye when we received it. Let's see here. We said that, and so our pictures, the cornea is always at the top. So there's the cornea, and here's the back of the eye back here. This looks like it was probably the second half of the globe because we don't have the optic nerve head captured here. So in other words, we didn't photograph it at first, but we went back afterwards and photographed the remaining second half. So what we have here is the anterior uvea. So the iris is kind of light yellow here. And then this, I think, is what would be the pupil with a really robust membrane across it. And so it's kind of folding down. In the posterior chamber, we have a lot of iridociliary tissue that's sort of reaching toward, you can see all these little delicate tendrils, reaching toward this accumulation of some off-white material in the posterior chamber and in the anterior vitreous. It sort of spans the division between the posterior chamber and the vitreous. The retina is not well captured here, but I wonder if this is part of it. I'm trying to remember now what it looks like. And then, so I believe this is the subretinal space that contains some hemorrhage as well as some clear fluid. So from this view, the lens is not obvious. And you can also tell that the globe is a little bit misshapen. So it's pretty common whenever you have dense membranes in the sort of posterior chamber / vitreous, they often contract and cause a little bit of a waist formation in the eye. So that's probably what's happening right here. Okay, so having said that, let's go ahead and jump into, the other thing that we noticed is that this globe was pretty crunchy when we cut it. So we actually decalcified it for a couple of hours before submitting it to histology for processing.
While you're getting this, like, the histology out,
yeah.
Is there a specific anatomic localization for that waist formation? Is it aura serrata or is it random?
Typically, it's due to membranes that do extend from the ciliary body surface and kind of traverse. It really is the boundary between the posterior chamber and the anterior vitreous. I've never really thought about the specificity of aura serrata. It could be, or it could also be the pars plana, the flat part of the ciliary body. But we might be able to answer that question when we look at this. All right, let's do our magic low mag view. What's that? Ta-da. All right, so I like to put the cornea at the left. So in this image, the cornea is at the left. And it's hard to get everything in focus with this view. But there's our cornea looking actually pretty unimpressive. Then we move back into the anterior segment. Here's some iridoid tissue kind of reaching across there, and here's a little bit more of it, and a little bit more iridoid tissue that kind of spans the pupil. It's not entirely sampled in this slide. Down here you can see this is also iris. Here is some of that white tissue that we were seeing in the posterior chamber and anterior vitreous. So we'll take a closer look at this. This is actually lens and lens capsule. That is very abnormal. There is also some dark purple stuff here, which we'll take a closer look at. There's also some bright pink / purple stuff here, which we'll also take a look at. And then there's the hemorrhage. I believe this is still the subretinal space. And then this is the half with the optic nerve head, and it is sampled here. but not entirely sampled. And then we had a little bit more. We have an extra slice that we'd like to call our gonio slice. So here's the cornea there. Here's some iris. No, I lied. There's the cornea. And here's some more iris. Here's some iridociliary epithelial hyperplasia. So all these little tendrils of dark tissue are the hyperplastic iridociliary plicae. And then there's a little bit more of that tissue, which is actually bone. So that is why this globe was crunchy. All right, so let's go ahead. So we'll start back up here at the cornea. So as I said, the cornea was actually pretty boring. I'm not surprised. Well, I'm actually a little bit surprised that this globe did not have a high IOP, given the lack of ciliary cleft in trabecular meshwork, where that aqueous humor outflow should have been occurring. It's possible that the iridociliary epithelium was unhappy enough that it wasn't producing or overproducing aqueous humor, aqueous humor. All right, so as I said, the iris is quite distorted. Here it is. There's some little tendrils of iridociliary epithelium extending from the back. And then when we move backwards, here we are on the ciliary body. This is the pars placata, because this is where the ciliary body plicae extend from. Normally, these zonular ligaments extend from the tips of the ciliary body plicae and suspend the lens in the center of the posterior chamber. However, there are no zonular ligaments left in this globe, I don't think. Here we're moving back into the pars plana, which is the flat part of the ciliary body. And then here we have that tissue, which is actually bone. So this is abnormal. Normal eyes should not contain bone. And there are bits, it's still partially mineralized because this globe wasn't entirely demineralized before we processed it. Let me go back out for a sec. More in the sort of center of the globe, we have this very thick basement membrane here, which is the anterior lens capsule. It's very convoluted, it's multifocally discontinuous, and I'll show you some. These discontinuities are a little bit hard to hang your hat on and say, like, yes, this lens capsule was ruptured. But there are some other areas where it is, I think, not arguable, that it is definitely ruptured. So here's the other side, more of that iridociliary epithelial hyperplasia. This pale eosinophilic material is collagen, so this is intraocular fibrosis. This is a very common finding in abnormal cat eyes, especially when trauma has been involved, and it often interdigitates with that hyperplastic iridociliary epithelium in the posterior chamber. Here's more of the bone. And then when we move slightly backwards, this dark purple stuff is mineralization that is associated with the lens. So I think this is actual mineralization in the lens, which is common in advanced cataracts. We move a little bit further back. Here is what one of these, possibly both, is the artist formerly known as retina. So it is very atrophied and detached. And then when we move backwards even further, we have these really dense cell populations on the surface of what is now the exposed choroid. Here's the tapetum. So this is the dorsal half of the eye. And as we move backwards, that really dense cell population is still present on the surface of the choroid. Sorry about the cover slip scratch here. Thank you, plastic cover slips. And so this globe has a number of really important lesions. So we're going to jump right into here because this is the most concerning lesion for this eye, is this population of cells. Oops. So we have a mix of cells that are sort of on the surface of the exposed choroid, and then we have cells that are in the what is actually a fibrovascular membrane on the surface of the choroid. Here's the tapetum. And this is the ventral half of the eye. So the tapetum thins out and then tapers away in cat eyes. And then here's the choroid proper. So let's take a look at these cells. Oops, sorry. So these cells are round cells that are individualized. They are relatively large. So if we look over here in the choroid, all of these small guys are lymphocytes, and they are a more typical size for quote unquote inflammatory lymphocytes. But out here, these cells are quite large, and this is actually a mitotic figure. And so they aren't really forming any structures. So this is characteristic of a round cell population when they don't form any particular arrangements or structures. They're just more in sheets. And they're quite large. So the nucleus of this cell is quite a bit larger than the nucleus of these inflammatory lymphocytes. So this is concerning for a neoplastic population. There could also be a mix of macrophages in here as well. We did not end up doing IHC on this eye, at least not yet, but I am concerned that this is a population of pretty ugly looking neoplastic lymphocytes or lymphoma. And we can go look at what they look like in another area real quick. We're going to zip up here. So here's just another view of them. Here's a big old mitotic figure right here. So these are some pretty ugly round cells. I assume this is lymphoma. And given the host of other lesions in this eye, including lens capsule rupture, and also the history of trauma or suspected trauma to this eye years ago, I think this is a post-traumatic lymphoma, which is hopefully eventually here going to be renamed chronic uveitis-associated lymphoma. That is usually associated with advanced cataract. And advanced cataracts in cats are often due to trauma. So sort of various chain of events, but we're going to call it chronic uveitis-associated lymphoma. So there's that lesion. Let's go back up here to the posterior chamber and goggle at some of these other things going on.
Out of curiosity, so a lot of lymphomas will affect the iris.
Yeah.
And this is kind of looks like it doesn't. That's one of the distinguishing features, right?
Yes. So good point. So the comment was that this lymphoma population does not affect the iris, unlike most lymphomas in the eye. That is true. And actually, this sort of posterior segment involvement is a little bit more common with the post-traumatic or chronic uveitis-associated lymphomas. If this was an eye was allowed to go quite a bit further in the cat's head, we typically assume that most of these post-traumatic things become circumferential and then affect the eye in like the entirety of the eye. So this is probably an earlier stage. That's what I proposed in this case, is that this was an earlier stage of the post-traumatic lymphoma. And they often will begin kind of loosely associated with the uveal surfaces and the exposed choroid and or retina. So yeah, that's a good point that differentiates it from the more garden variety lymphomas. Okay, so moving back up the front here, this is our lens or what's left of it. So this is the anterior lens capsule. You can tell that because of how thick it is. And then let's see here. So this is some sort of membrane on the surface of the lens capsule, I believe, and this is the inside of the lens capsule, and we have mineralized material and some collagen. Collagen is the result of fibrous metaplasia of the lens epithelium, and mineralization is associated with lens fiber degeneration. And let's zip over here. So it's always important to try to decide whether you have true lens capsule rupture or whether it's artifact. Whenever you have an end of a lens capsule that is surrounded by similar material, just like this is a pretty good bet that this is a true site of lens capsule rupture. And whenever you have lens capsule rupture in a cat, you always want to worry about, is there also a post-traumatic sarcoma of the spindle cell variant, which originates from the lens epithelium? That is not present in this eye. So I was not worried about the spindle cell variant of the post-traumatic sarcoma in this eye. The bone is another interesting feature in this eye. Bone can form in the eye for various reasons. And I think cats are the champions. They do it more often than other animals. Mm-hmm. Maybe birds come second and then dogs come third. It often will be associated with either Brooks membrane, which is the basement membrane of the RPE, the retinal pigmented epithelium, so subretinally, or associated with the ciliary body, which is what this bone is. And this is also interesting because not only do we have bone, but we also have bone marrow in this bone. So this is actually bone marrow. Probably some of these cells in here are rubroblasts and red blood cell precursors, and then there's some other precursors as well. like these little guys here, that are looking like they want to be eosinophils. Interestingly, there were also eosinophils in the choroid. I didn't really dwell on the inflammation of the sort of choroid, or really the epichoroidal membrane. Okay, so let's go real quick and look at what might remain of the retina. Yeah. So I think you might just have to trust me here, but I believe this is the retina, this band here, that's very degenerate, very atrophied. And here's more of those sort of scary neoplastic round cells. Now, I don't recall if we've ever diagnosed a post-traumatic histiocytic sarcoma, but this one, I would be really interested to see what a histiocytic marker would look like on those cells, or if these are all going to be neoplastic lymphocytes. We used to believe that most of the quote-unquote post-traumatic lymphomas were B-cell lymphomas. However, they can actually be B or T. I think B is more common, but they can actually be T-cell lymphomas as well. Okay, and then the last interesting feature of this eye was associated with the choroid and the epichoroidal membrane and sometimes the neoplastic cells. There's some of this weird fibrillar eosinophilic stuff. And I did not do a Congo red stain, but my gut feeling is that this is probably amyloid. So there's a little bit here, and maybe here you can kind of appreciate some of the inflammation that I didn't really point out very clearly, except to compare the lymphocyte size. So there's some of it there, and then there's more of it somewhere else over here. So I think there's also amyloid, which can be produced in the eye when you have a significant chronic inflammation, and some lymphomas themselves can produce amyloid, B-cell lymphomas. Okay, so that was a whole host of interesting lesions in this eye. Let's go back to our PowerPoint to talk about the list of diagnoses. And there's a bunch. So there you go, suspected trauma. So this kind of fits into my suspicion of the post-traumatic lymphoma. I forgot to include the new name of the chronic uveitis associated lymphoma. And that's a presumptive thing. Lens capsule rupture with hypermature cataract, this intraocular osseous metaplasia with extramedullary hematopoiesis, or maybe it's not extramedullary when it's actually in the bone marrow of the bone. I'm not sure. Certainly not in the normal. Bone marrow hematoma. Okay, nice. Anyway, posterior synechiae with iris bombay. I didn't really dwell on that. As I said, the iridociliary epithelial hyperplasia and intraocular fibrosis are very common findings in abnormal cat eyes. And then we had a little bit of inflammation, which was kind of mixed, and the eosinophilic component was kind of interesting. I don't really have a good reason for that, unless perhaps what I was looking at was more actual extramedullary hematopoiesis there in that fibrovascular membrane. And then presumed multifocal choroid amyloid accumulation. So this was just an interesting eye with a whole host of interesting lesions, and I thought it was interesting to share. So any questions, comments, chat, anyone?
One comment.
Yes.
We do see plenty of lymphomas recruit eosinophils.
Okay, oh, good point. So somebody piped up, Dr. Gasper piped up and said that many lymphomas will recruit eosinophils, so that might be part of what's going on here. And yeah, good thought, good thought. Okay, cool. So let's move on. I don't want to take up too much of our time here. So the next case is also an interesting cat eye. This is an eye from a 2-month-old kitten. He's a male intact kitten. The history we got was, this is the right eye, buphthalmus, exophthalmus, and lagophthalmus, episcleral congestion, corneal scarring, vessels, edema, and deep axial ulcer associated with keratomalacia, moderate iris hyperemia, shallow anterior chamber, meiosis, 1+ aqueous flare, hyphema, with settled red blood cells ventrally that take up about 1/5 of the anterior chamber. So here is the globe. As always, the cornea is at the top. Whenever you see opacity in the cornea, that's either going to be edema or inflammation or fibrosis. So we also have somewhat subtle corneal thinning in that area. That's axial in the center. So we move back into the eye. We're basically looking at the back of the iris, and you can see this is the pupillary margin. So the pupil is right about there. There is not a very well-defined anterior chamber except axially where the pupil is. So this area of the anterior chamber is a little bit obscured or occluded by maybe some iridoid tissue here. As we move back, the lens is milky white, which is actually really common in young animals. Remember, this cat is only eight weeks old, so it's pretty common in animals that are this age. And it's also kind of flattened in the anterior to posterior plane. That is also common in young animals. So it's hard to grossly diagnose a cataract in a young animal. I think their lens fibers are just not quite well organized enough to be the optically clear media that we expect in a mature lens. The retina is detached. And you can also, they talked about the hyphema in the anterior chamber, and there it is. We did sample a little bit of it. So the retina is diffusely detached. And then we have this weird little nubbin of stuff here that we did actually manage to sample in this section. I wasn't quite sure what that was. So that is those are the gross findings of this case. So let us go ahead and jump into our slide. All right, so cornea is to the left, and you can maybe appreciate. There is actually an ulcer as described clinically. So this is the epithelium is here, and then it ends. It's also detached. And then we have this area of stromal thinning, so there's stromal loss associated with this. We'll look a little bit higher at that at higher magnification. Here is some of the blood in the anterior chamber. You can also see this interesting connection of the iris to the back of the cornea. When we look at the iridocorneal angle, the ciliary cleft is not terribly apparent, so we'll take a higher, we'll examine that more closely. Same on this side, and in fact, this one's even weirder, where you have iridoid tissue that kind of spans the iridocorneal angle here. So really no normal iridocorneal angle to speak of in this eye. The lens, as I said, is kind of flattened, and I think there is actually a cataract here, so we'll take a look at that. The retina is detached, and from this magnification, you can kind of make out that here is an area where you can make out some of the nuclear layers of the retina, and then as we move peripherally, they get a little bit sparse and maybe not quite as numerous. There should be more cell layers of nuclei in the retina, and then there's that little accumulation of stuff, which is kind of a minor point. But anyway, in our extragonio slice, in this case, the cornea is down here. We have an area where we have rounded end. The retina is discontinuous, and we have rounded ends. So that's an area of retinal tear. So those are our main lesions to see on the subgross level. Go ahead and start in at the front. So whenever we have epithelial, we have a corneal ulcer with epithelial non-attachment, which is what we have here. The epithelium often loses its polarity, so you can no longer tell what the basal layer is and what the more superficial layers are. This is common when the epithelium is truly detached, and so we call that loss of polarity, and this is consistent with an indolent corneal ulcer, if you've heard that word. If we zip to the other side, maybe somewhere in here, we could almost convince ourselves that we have epithelium sinking into what would be a lytic anterior corneal stroma, so this is consistent with collagenolasis. This is not the best example, but we also have a number of blood vessels that are coming in and populating the peripheral corneal stroma, which are in response to that corneal ulcer. And then, as we look deeper, here is Descemet's membrane. It's quite thin, which is normal in a kitten. And then we have a retrocorneal membrane as well. And if we follow that retrocorneal membrane, it kind of joins up with this iridoid tissue that is adhered to the back of the cornea. So we have at least a focal anterior synechia that's more axial in this area. We can see those red blood cells. There's the hemorrhage. And the iris is obviously quite distorted here. It shouldn't have this arm of tissue reaching forward. And here's the iridocorneal angle on this side. So we actually have iridoid tissue that really does span the iridocorneal angle right here. So we don't have an apparent ciliary cleft. Let's go to the other side because I think it's niftier. And here's a similar one where we do have some white space, which you might argue is the ciliary cleft, but there doesn't really seem to be much of a ciliary cleft opening. And also Descemet's membrane, or this iridoid tissue, really does kind of join right up to Descemet's membrane here. So this is a very abnormal iridocorneal angle. It is a young animal with ophthalmos and glaucoma. So this is, we now have an explanation for the ophthalmos and the glaucoma, and that the iridocorneal angle and the aqueous humor outflow tract is occluded and abnormal. So this is consistent with anterior segment dysgenesis in a young animal. This is one of the forms that it can take. Let's go take a look at the lens now. All right. It's a little bit wrinkly. That's artifact. We're going to look at the back side of the lens, the posterior side of the lens. So normally you should not have lens epithelium lining the posterior lens capsule, which we have here. So this is consistent with at least a posterior, a subcapsular, posterior subcapsular cataract. That's what we call that when the epithelium migrates posteriorly. So there is a cataract here. And then let's go examine our retina. Move back. So here's our optic nerve. Here's the optic nerve head, which is distorted by the diffusely detached retina. And so here's the central retina, and we really are lacking at least a nice organization of the nuclear layers. So these are some of the outer nuclei, which is the nuclei of the photoreceptors. And then probably right here is the inner nuclear layer. The ganglion cell layer is absent. So those guys should be in this area. In this central area of the retina, we have at least one little blood vessel. Maybe there's another one here. Let's check out the other side real quick. So we have a few other blood vessels. But when we move more peripherally, and also keep your eyes open to look for ganglion cells, and I'll tell you that there aren't any. As we move more peripherally or away from the optic nerve head, those blood vessels completely disappear, which is abnormal in a cat retina. So the retina of a cat and a dog should be vascularized all the way out to the periphery. And what we have is just this complete absence of really sort of paracentral to the periphery. We have a total absence of vascularization. And what I didn't dwell on at the lower mag or earlier is that we also have this tissue that's sort of extending from the optic nerve head into what would be the vitreal space. And so we have very pale eosinophilic fibrillar material and a number of blood vessels embedded in there. So this is what we call a papillary intravitreal fibrovascular membrane, PIVM. So those are the main features of this eye. And this stuff accumulating here, which I just thought was interesting grossly, it's just some fibrin or collagen with some entrapped red blood cells and some melanin-laden macrophages. And there are also some blood vessels here. So we also have this sort of subretinal vascularized membrane as well. So we have a number of different interesting things in this eye, and I've gone over my time really allotment. So let's go ahead and zip over here. Okay, so we have diffuse retinal detachment and tear, extensively absent vascularization and a focal tear of the retina. This is suggestive of or consistent with what we call feline neovascular vitreoretinopathy. There was also anterior segment dysgenesis. I didn't point this out, but preiridocorneal fibrovascular and retrocorneal membranes causing focal anterior, axial anterior synechia, and then glaucoma as per history, which was presumed congenital. So this, many of these features are common in this entity called feline neovascular vitreoretinopathy, which is an interesting syndrome and often diagnosed in younger animals. Approximately half of the patients will have abnormalities in both eyes, but they might be of varying severity. And presumably it's something congenital. So it's some abnormality of ocular development that leads to all of these lesions. I don't know how much further I want to go because it would take more time. But any questions or comments about this specifically? Okay, cool. This is a pretty rare condition. So, all right. Oops, I shouldn't have done that. Okay, now it's somebody else's turn. Megan's turn.
All right, we have another cat for you. My name is Megan Kleinmans. I'm one of the staff pathologists at Coplow. And this is the case of a 10-year-old neutered male domestic short-haired cat. Clinically, they describe a corneal mass of the right eye, raised, non-pigmented nasally. Let's see, they did a cytology, which came back inflammation. They then did a snip biopsy with not Coplow, I believe, which came back a diagnosis, which I will withhold for now. Let's see. They described some macular corneal opacities with pigment, which is interesting. And that's kind of it. So mostly we're talking about surface disease in this case. So let's take a look at the gross photo. Here we have our mass. And in the formalin-fixed post-sectioning specimen, we can see that this mass is pretty red. And it's sort of multiloculated or sort of like multifocally cavitated, which are interesting features. In addition, so you can kind of compare the iris way down here to some of this stuff that's plastered against the back of the cornea at roughly the level of that mass. And it looks kind of similar. So there's a sort of pigmented or yellowish tissue against the back of the cornea, right where this mass has developed, and the corneal stroma itself at that site is also a little bit thin. So all interesting features. And I think that's the main things that I would want to point out grossly, and we'll move to the histologic stuff, which is, wait for it.
Nope.
There we go. I don't know why my brain was blind to that. All right. Let's see. Let me try for a subgross. We'll need that one. There we go. Okay, so cornea is on the left, and we have a nice subgross of that reddish mass. And from low magnification, you can see these big chambers full of pink and red, which is interesting, and these smaller little red foci. Again, with the thin corneal stroma at that level, and again, with the pigmented tissue plastered along the posterior cornea. Let's see if we can find the gonio slice here too, because that's also of interest. It's probably more interesting closer to, because it's a little bit hard to see what's going on from low mag. We'll go closer to it. Let's see, I think I actually need to put it this way to make it the same orientation, right? Nope. Wait,
Yeah,
yes,
that was right.
that was correct. All right. So here we are back at this mass, which is the main event. So this mass is maybe slightly into the bulbar conjunctival substantia propria at this level, but the vast majority of it is in the superficial cornea, which is very interesting. And if we look closer at what all is a part of this mass, we have these anastomosing beams of collagen, which are lined by spindle cells and delineate blood-filled vascular channels. And in some areas, the cells are actually pretty low profile and not very pleomorphic. And in other areas, they get a little bit more plump and sometimes kind of infiltrate their own stroma in intersecting streams. And the pink and red that we could see from low magnification is that some of these vascular channels are full of fibrin, which is something that can happen with these dilated and aberrant channels. Ended up calling this a corneal hemangiosarcoma. It was between that or a hemangioma because a lot of it is actually fairly low profile cells. And the interesting thing about corneal vascular tumors is that, assuming you can rule out that it may have originally arisen in the conjunctiva, which may be because there is a little bit of this mass in the conjunctiva, but given that the majority is in the cornea, it probably arose in the cornea. Because the cornea is a relatively avascular structure, it shouldn't be that we have a lot of endothelial cells to form a tumor in the first place. So from that, corneal hemangiosarcomas or hemangiomas presumably arise in corneas that are becoming vascularized for some other reason. So there's probably a pre-existing corneal disease in many of these cases, and then the tumor eventually arises. And to that end, this case has some cool features. So let's check out this area here with that pigmented tissue that we saw grossly. And we can see that at that site, Descemet's membrane is discontinuous, and then it's gone. And we have this iris-like tissue, or it's most likely just iris, that was plastered against the posterior cornea at that site. And the corneal stroma itself, we'll actually go one back, at the level of this mass, has these thickened and disorganized collagen fibers. So this was most likely new collagen that was laid down at a site of a corneal defect. So these features are suggestive of the sequela of a corneal perforation at some point in this patient's life. So this cornea ruptured, it kind of healed over, and then presumably the mass arose because this area was vascularized in the first place. So that's kind of a neat feature.
There's also a chance, like we see sometimes, that the vessels are coming from the prolapsed retina, prolapsed iris.
That's a good point. The iris could have brought the endothelial cells there. Yeah. So some additional features of this cat that are nice. Let's head briefly along those same lines over to the gonio slice. There's still some goo here. Hang on one second. Let's get rid of the goo. It's still there. All right, we'll just crack on. Let's see, we're going to leave that out. This is just showing off how the iris sort of focally fuses with this anterior synechia at the level of the mass. Basically at that other level, we didn't see the iris leaflet itself communicating with the site of rupture. Here we do. This gonio slice also shows off that the posterior iris has developed these thick-walled cysts of the areociliary epithelium, which is something that we see relatively commonly in cat eyes with trauma. But also is kind of just a non-specific thing. And then the last thing to kind of clean up with this cat eye, I'm actually going to go back over here real quick. So in the conjunctival substantia propria, bulbar conjunctiva, we have these tubules of epithelium. And this epithelium has many goblet cells to it. There we go. And so this is a very conjunctival phenotype to these tubules of epithelium. And these are conjunctival inclusion cysts. And in fact, one of these cysts at this level has actually ruptured. You can see that the epithelial lining is discontinuous here. And there's a little bit of inflammation, presumably associated with this secretion from that conjunctival epithelium. So that's kind of neat. And the other thing that's cool about this gonio slice on the other side, now that we've shown you the bigger ones, we'll go back here. Still with the goo. You can actually kind of see the conjunctival epithelium folding on itself here at the fornix and kind of coming down into those inclusion cysts at that level. So
as you go lower mag,
yeah,
because there's pretty nice and bluff around too. It's like if you go back to the other section, from low mag, you can keep going more axially. You can see how there are goblet cells in the epithelium, and it continues right over the corneal surface. So actually, we have some blepharon, which is where the conjunctiva extends over the cornea, and then we also have conjunctivalization of the corneal surface.
Yep. So these features are things that we see commonly in viral keratoconjunctivitis, especially feline herpes virus 1 infections. They are not necessarily specific for a viral infection. But that would probably be the top differential for what caused the symblepharon, the conjunctivalization, and the inclusion cysts. And you wonder if it contributed to the initial corneal disease. Really neat case, kind of a twofer. So here's some of the key diagnoses. If there aren't any questions or comments, we'll do the next case. Okay. This is a really unusual case. I'd definitely be interested in other pathologists' opinions on it as well as showing it to you. So this is a 3-year, 9-month-old neutered male Chihuahua. And let's see, in this eye, yeah, it's cool looking. I hadn't noticed I didn't have a good history for this eye printed, so apologies for that. The main thing to point out is what we'll show you on the gross, and the patient didn't really have any obvious systemic signs, which will become significant later. The other eye has an immature cataract, but it was otherwise originally doing okay, but I believe it developed similar uveitic type signs a little bit later on. So that's also significant. But no obvious, just general medical conditions basically at the time. So in the gross view, we have possibly posterior synechia. We have iris plastered against the lens. The cornea is a little bit cloudy. The lens is a little bit cloudy. And then the main event is, of course, the retinal attachment in the back. You can see that this is tissue here is the retina. And then subretinally, there's a cloudy gel. And this would have been a gel, basically, if you could manipulate this globe yourself and maybe prod it slightly with a pair of forceps. It would be a stable gel. So this usually suggests that it has a high protein content. Kind of interesting from the gross view as well, we have this hint of tan tissue sort of plastering uveal surfaces and retinal surfaces, and you can actually see these little brownish dit dots from low magnification, or from gross view, which we'll look at closer as well. It is low magnification technically. All right, so.
So I found the, go ahead.
It's Chihuahua.
Oh, thank you. You found the
Yeah.
clinical description of the eye. Thank you.
Pull out the history here. There's not much more than what you said, rather than 2+ aqueous flare, and develop a superficial corneal ulcer. They've enucleated, and they were wondering of a lens-induced uveitis. They were suspecting retinal detachment, and a secondary glaucoma.
Cool.
And as you mentioned, nothing specified on medical conditions, like systemic medical conditions.
Thank you. Yeah, this was one of the cases where it was uploaded into our new limbs, and I hadn't noticed that the history was just see the original form, and the original form hadn't been printed. So thank you very much.
There's some information we called Dr. Sturt. Do you want to save that for later?
Probably.
Yeah, let's save that for
Okay.
later.
I figured.
Right. Okay. I think we're gonna, yeah, actually do that, and then that. All right. So the main event here is indeed the detached retina, which we saw on gross. So you can follow it here, forming a little tornado of sorts. And the pinkish hue of that whitish cloudy gel subretinally at the gross is indeed suggestive of a really high protein fluid. And we have some cells, which would have been, you can kind of mentally put them back where they were initially. This is probably an artifactual separation on the slide. Some cells that were lining the retinal surfaces and part of that tan carpet. And then in particular, you can also see that parts of the uvea look a little bit too purple as well. So here's this really thickened and very cellular choroid, for example. And then also of interest, we have this iris leaflet up here, which is looking a little bit weird and purple. So let's take a closer look. We're going to flip it this way. Okay. So I'm going to still focus on the posterior segment, which is where a lot of the action is. Although actually, but first we'll go to the iris leaflet, I think, and then we'll go to the highlight. We'll first on the iris leaflet and then the posterior segment. So this iris actually looks very interesting. The cells that were there are actually associated with blood vessels. So you can see that they're forming these round cross sections, and actually they're filling the blood vessel lumens in many of these foci. So it's hard to be super confident, or if it is hard for you to be super confident, we can find some other areas maybe where they're clearer. Actually, I think we'll stay over here. Here we go. So just confirming for you that these cells are in vascular lumens, we have a clear endothelial lining in a lot of these to show it off. And if we look closer at the cells, they're a round cell population. And they have a fair amount of cytoplasm, which is kind of foamy, and they have fairly large nuclei. And if you look around, they tend to have a pretty high mitotic rate. We can see them not only in some of these larger iris blood vessels, but they're traveling in some of these smaller clusters, probably in smaller diameter vessels as well. So getting you a good look at these unusual round cells. And here we go, some of the smaller blood vessels. This is the one I had in mind that I really wanted to show you. You can see these big atypical round cells in the lumen of this small blood vessel here, for example. Okay, so now let's go back to the posterior segment and take a closer look at that. And interestingly, if you look at some of these cells that were lining the retina, a lot of these are actually just macrophages, some of which have pigment in them, which explains that sort of multifocal pigmented stipply look from gross view. And they're admixed with lesser numbers of neutrophils. So there is a significant inflammatory component here. However, if we go back to the choroid too, for example, while back here we have a lot of inflammatory cells, no doubt admixed, there is this significant component of these atypical large round cells still forming sheets. And again, with a fairly high mitotic rate and kind of a vascular component. We're going to land on one and stop just migrating along slowly because people want to get a good look at it rather than just seeing the migration. We can go higher. We could go higher. Yeah. So this is a really weird case, and ultimately landed on these round cells being in neoplasia. This patient is a little under 4 years of age, and the tumor that might be a round cell neoplasm of a young dog would probably be lymphoma. So the top differential for this case is lymphoma. But it's weird. It's got a significant inflammatory component associated with it. It's got that really robust subretinal fluid, high protein fluid. And the patient has no systemic signs, and yet these atypical cells, which are presumed neoplastic, are packed into vessel lumens in the uvea, which implies either that it's going somewhere from the eye or that it arrived from somewhere else to the eye. And so suggested in this case, staging, checking the local lymph nodes or just lymph nodes in general would probably be useful for this patient. Offered immunohistochemistry, and they had yet to take us up on that. And then I do believe we did get additional information about the other eye. If you may want to read it directly from the thing, if you still have it.
Yeah, let me open it up. So we have additional information, we call them, and they said the patient had pressure spikes and sudden vision loss in the remaining eye. No evidence of inflammation or neoplasia on the eye itself. A little malaise and rapidly decreased albumin, elevated total protein on blood work. No leukocyte atypia was noted. The patient was anaplasma positive, which is not uncommon in the area, and no systemic signs apart from the malaise. So,
yeah,
mystery.
Indeed. So a very unusual case. It's not a common presentation in the eye and just in general. Yeah.
That's a good question.
Oh, of course, please.
In the first case with the cat that we were talking about, you were talking about the post-traumatic chronic uveitis lymphoma. I know that this is a dog and there's like no history, but is that a thing that happens in canines as well? Is it only mostly in cats?
We don't typically recognize it in dogs. I think cats are sort of more the poster children of transformation of chronic lymphoplasmacytic inflammation to lymphoma in a variety of locations in the body. And yeah, not as well documented in dogs in general, I would say. And certainly we don't really have a lot of cases that we'd be willing to label that way in dog eyes.
We have a very small handful of the post-traumatic sarcomas in dogs with lens capsule rupture and presumed lens epithelial origin, but like 10 total.
Yeah, and
So-
that's presumably a somewhat different pathogenesis. In
Yeah.
cats, the thought with chronic uveitis-associated lymphoma, or quote-unquote post-traumatic lymphoma, is that it is a chronic lymphoplasmacytic inflammation that transforms, versus post-traumatic sarcoma is a lens epithelial origin, usually following from lens capsule rupture. So, yeah. I guess go ahead.
No, but
I guess the short answer is no, we haven't diagnosed chronic uveitis-associated lymphoma in dogs.
Okay.
That's a short and efficient one.
so Kara suggested an endotropic vascular lymphoma.
Mm,
I think we talked about it, right? when
we
were
did. So
checking this one
I
out.
didn't want to call it a intravascular lymphoma because while the iris is very much sort of like it's in the vessels and not really in the stroma itself, the choroid, it is kind of in the choroidal stroma as well. I mean, it could be spilling out of the vessels to some extent, but I guess I would be more happy to call it that if it were mostly confined to vessels rather than infiltrating the uvea as well. But I could be wrong about that, basically.
The high protein stuff is probably mostly associated with unhappy vessels and leakiness. So
Right,
I think
that's a
it's
good
sort of
point.
a secondary, slightly interesting, but just a secondary lesion. I mean, and although they reported decreasing albumin and
Yeah.
total protein elevated,
Elevation,
so presumably globulins,
Yeah, presumably.
which might be
Right.
It's
good for a
weird.
B cell lymphoma.
Mm-hmm.
No, decreasing albumin, it should stay the same.
Oh, okay.
Yeah.
Never
I mean,
mind.
there's also this
That suggests
inflammatory
there's something.
component.
Unless it's a protein losing somethingopathy,
Mm.
I didn't hear.
bodyopathy, somewhere.
He said unless it's a protein losing something, basically.
Yeah.
But
But I mean, if you got this, albumin's an acute-based protein, so it should increase, especially if it's gone this long. Just to ask the devil's advocate, did you do any special stains on this?
no.
What was the question? Can you repeat
Did we
that?
do any special stains on this?
You know,
Yeah, I mean, it might be worth doing like a PAS for fungus, for example, or another fungal stain. Yeah, I mean, initially from low magnification in particular with like the subretinal macrophages kind of clustering along surfaces, it's and mostly affecting the posterior segments. Fungal disease was sort of the first thing that came to mind until I saw these big atypical cells in the vessels and in the uveal stroma. But it might be worth doing a special stain and at least taking a look.
I was just curious.
Yeah.
Those don't look like your typical neoplastic round cells.
Mm. I mean, there are a lot of-
I figure there's a lot of features of atypia. I've seen a couple of cases, things like erysipelathrix that have this sort of pattern with all those macrophages. You don't always find a lot of bacteria in them.
Interesting.
Bacillary angiomatosis, there was more wall proliferation.
Hmm.
Probably tumor.
Yeah, I mean, it might be that these are just really reactive, like kind of lymphoblasty type phenotypes in chronic inflammation. Yeah, we did actually suggest TVT in the comments. Gillian whispered TVT. We asked about travel history. I can't remember if we specifically got an answer about travel history. While we were on the phone, I could have thought of that, but I'm not sure if I did. Yeah.
No,
Particularly given that these cells kind of have more cytoplasm, like a larger amount of sort of foamy cytoplasm than I might expect for lymphoma. So I believe we called this one just round cell. Let's see. Come on, mouse. There we go. Yeah, round cell neoplasm. And suggested staging. And then gave them some differentials and offered IHC, which we haven't done yet. So, yeah.
Let's get Jamie to present.
Yes,
Please,
right.
before it's too late.
So much time.
Squeeze one.
you know,
We've started rotating so that not one individual has this happening all the time.
That's all right. Guess I'm happy I put this one first before the other one. So this one should hopefully just close us out here for this last time that we have here. Make sure I got the right one. Okay. This is the right eye from an 8-year-old mixed breed dog that Has a vague history of a corneal mass, according to a specialist. The owner declined an ocular ultrasound, so they removed the eye. And they just said growth on cornea with no specific location on the cornea noted. They said no glaucoma, but it's been going on for 12 months. The other eye is normal, and the dog is generally hypothyroid. And so grossly, there was some corneal opacity and slight thickening ventrally to the cornea. And on cut section, what that was due to this white mass effect here, kind of either posterior to the cornea or in the cornea. We've got, our iris leaflets here, lens, and there really was no connection to any other part of the eye other than the cornea. So very corneal centric disease, and posterior segment is all pretty unremarkable there. So we're going to, oh my goodness, I've lost the mouse. I see it, it's down at the bottom. I am moving the mouse. Oh my goodness. Here we go. Okay. I'll go a little bit slower maybe. Okay. All right. Again. All right. So subgross here. We've got cornea again on the left, and we can see where that kind of thickened white tissue here is this region of hypercellularity here in the deep corneal stroma. And looking at the rest of the globe, it was fairly unremarkable. So we're just going to concentrate right up at the top where the cornea is going to show us what's going on. All right. So here it is, again, very deep in the corneal stroma here. We can see that this infiltrate causes some wrinkling here of Descemet's membrane. Gets a little bit more cellular on the one edge. If we get a little bit closer, it's a population of spindle cells. Get it in focus here for you. That's dissecting here in between the corneal stroma here. Very much streams, maybe intersecting bundles, a few blood vessels, but just kind of bland looking spindle cells coursing through the deep corneal stroma. And if we head towards the one edge here, they get a little bit more pleomorphic. Here, they have a little bit more increased anisocytosis and anisokaryosis. It's got a little bit more of kind of like a herringbone pattern that we can see with sarcomas. And I think there might have been a little bit of kind of some larger cells here, maybe some multinucleated cells here as well. So it was a little bit perplexing. It's pretty much just a spindle cell population, not much inflammation or other stuff going on. We considered things like fibroplasia or granulation tissue from a previous deep corneal abscess. We considered reactive histiocytosis sort of thing. Both of those probably would usually have a more inflammatory component mixed in with it, some lymphocytes, plasma cells, maybe some neutrophils. But we didn't really see much of that going on. So we tried to go a little bit deeper into the blocks, see if we could catch a little bit more of what the cells are doing. We did 3 deeper sections. I'm only going to show you one sort of representative section.
There was a storiform pattern in there.
Yeah. So
That's not reactive.
right. So the one area had a little bit, like I said, more of a sarcoma look to it. So we did go with some deeper sections to see if we could catch more of that pattern. But it was a little bit more blander, kind of the deeper we went into the block. But again, a little bit more atypia, a little bit increased more cellularity. And we did have some leftover tissue in the jar because we really wanted to see if we could catch more neoplastic looking features. And so we went back to the tissue and we took another slice of the cornea. And here it is, again, looking a little bit more neoplastic in this side where it's a lot more hypercellular. We got more streams and herringbone patterns and more atypia to the cells. Again, very minimal inflammatory component with this. So we landed on this being a deep stromal sarcoma in the cornea, which is not very common in our cases.
In anyone.
In anyone. So yeah, we probably don't have very many of these in our database, and it was just kind of a interesting
Yeah, it was
case.
weird. Another weird thing was the fact that there was almost no reaction whatsoever in the cornea around on the stroma. It didn't look like there were any signs of chronic corneal disease that would suggest something reactive. So after spending probably too much time going deeper, and I think we kind of assuaded our doubts, and we went with it. So
First time I've ever seen it.
And then just general, probably just primary corneal, pretty good prognosis. They got it all. It was all localized to the cornea, not expected for metastasis or anything like that in our very low numbers. So fairly good news for the dog. So
Did you use the soft tissue sarcoma grading scheme for it?
no, did not.
It's kind of soft tissue. I mean, why not?
softer.
Yeah.
Nope. Grade 1.
Yeah.
All right.
Yeah.
Thanks, everyone.
Yep.
See you all there online. And I'll see you guys in 2 weeks.
Thank you.
Have we had any emails from Linnea?
That would be here. So stop recording. Okay.